Good morning, everybody. It's a couple of minutes past 5. We're going to start here in the Netherlands. I believe it's 1 o'clock in Korea, so good afternoon. Let me quickly introduce the speaker of today. Dr. Ed Hendricks will be presenting to us. Today's lecture will be about obesity as a risk factor in COVID-19. Dr. Ed Hendricks is a renowned pediatrician, practitioner of bariatric medicine. He helped hundreds of people trying to lose weight. Next to that, he has won many rewards in for his research as a practitioner. He's also a former MDAC member. This means that he gave advice to the new obesity treatments. Therefore, I'm very happy that he's going to present us something about obesity, to present us something about the topic as in today's light with the COVID-19 situation. So, Dr. Hendricks, please take the floor.
Thank you. Today we're going to talk about obesity as a risk factor in COVID-19. Let's see. So, can we advance the slide?
Yes.
So you all know about COVID. I don't need to tell you anything about COVID. So we'll just touch on a few things. As you know, the first cases appeared in December 2019 in Wuhan, China. It was declared as an international health emergency in January of this year and a pandemic in March. I looked up just recently as October 25th, there have been 42.7 million cases and greater than 1.15 million deaths. Next slide. Go back one, please. Well, I was going to show you you people in, there we are. People in Korea did a much better job of controlling the death rate, and in Thailand and in Singapore, you did much better job of controlling it than we did in the USA or they did in the UK. This is from worldometers.info coronavirus. I'm sure you can find lots of other competing statistics. Let's go to the next slide. So an increased BMI is associated with a poor COVID-19 outcome. There have been a number of studies. There was a meta-analysis of 33 studies, including 45,650 patients. And it found that COVID-19 in obese patients had significantly higher rates of hospitalization, ICU admission, ventilator use, and death. Next slide, please. So obesity patients have elevated inflammatory cytokines. That's a hallmark of obesity, actually. It's an inflammatory disease, a systemic low-grade inflammatory disease, and some of the cytokines that are elevated include alpha tumor necrosis factor, MCP1, and IL-6. And the hallmark of severe COVID is cytokine storm. And the clinical characteristics are that the patient has fever, hypotension, and tachycardia because of COVID myocarditis. They have acute respiratory distress. They may have disseminated intravascular coagulation, which results in tissue infarction and ultimately multi-system organ failure. Next slide, please. This is another way to look at it. So cytokine storm leads to organ failure, and it's so increased clotting, shock, lung injury, cell death, immune paralysis, intestinal injury, and this all leads to organ failure, infection, and ultimately death. Next. So the symptoms, we mentioned all of these before, but uh, so multiple organ dysfunction syndrome with hypotension, tachycardia, respiratory failure, insufficient tissue perfusion resulting in ischemia and infarction, followed by uncontrollable hemorrhage and multisystem organ failure. Next. Now, as you know, obesity is associated with a number of comorbidities. I've just listed a few here. Patients with COVID and any of these comorbidities have poor outcomes. Next slide. So having said just a few words about COVID, let's move on and talk about treating the overfat, the overweight, and the obese. So I like to think of obesity as a dynamic process. I mean, it's unfortunate that the World Health Organization some years back decided to, and we all agreed, to call this disease process obesity, but we really named the disease for the end stage. So if you think about how many other stages there are several. It begins with overfeeding and overeating, and then early fat accumulation. One way to look at that is to call these patients overfat. In fact, that's probably a better term than obesity. For all of the stages, the patients have an increased body fat percentage. So rather than using a BMI, we should all be looking at how much fat the patient has. And because as that fat begins to accumulate, it becomes inflamed. And then that leads to more fat accumulation. And so we move from being overweight, from being overfat to overweight. The overfat still covers that. And then when multiple organ systems are inflamed, you have obesity. But once you get to obesity, the disease is irreversible. So treatment should begin much earlier. And so if you have a patient who comes in and says, I'm gaining, or I have gained weight, anybody who's gained more than 3 or 4 kilos since they graduated from high school is in danger of following this trajectory and becoming truly obese and having all these problems. Next slide, please. So if you treat and lower the patient's weight, then you lower the risk of all of these comorbidities: diabetes, pulmonary disease, cardiac and renal disease, liver disease, all of them. And you reduce the risk of COVID. Next slide, please. So Phentermine sustained release treatment benefits. So I've listed some of them here. It assists with weight loss in patients of all ages. So some of the studies that I've done, the ages of the patients involved have ranged from age 6 to over 90. So there's no problem using Phentermine at any age. The label says be careful with adolescents. That's an ancient myth as far as I'm concerned. American physicians have always treated adolescents as, with Phentermine if they're overfat or overweight or obese. Phentermine actually improves harmful eating behaviors. It does diminish hunger and cravings, so it is an appetite suppressant, but that's only one of the actions. Now, if you ask patients, how does it help? They invariably start talking about how they don't think about food as much, they don't eat as much, they don't have cravings. So Phentermine treatment in these patients improves their long-term outcomes, especially the ones with comorbidities. Next slide, please. So here's another short list of the improvements that you might see. You see improvements in diabetes treatment. You see improvements in heart disease, decreases in cancer risk, improvements in chronic renal disease, osteoarthritis, and about 60 other diseases. I always tell my patients, I've yet to find an illness that doesn't get better, an illness associated with obesity or with being over fat. I've yet to see one of those diseases not get better with weight loss. So phentermine has a wide range of benefits. Next slide, please. It's very low risk. So let's talk about risk a little bit. In my experience, the potential benefits always overwhelmingly exceed any perceived or imagined risk. So let's go through a few of the risks that the label says, and everyone knows that phentermine makes your blood pressure go up. But that, in my experience, that's extraordinarily rare. It's rarely reported in the literature. In my experience, I think I've probably treated somewhere between 30 and 40,000 patients with phentermine. And in that experience, I've seen exactly 3 patients whose blood pressure went up when we put them on phentermine. Each of the 3 patients had poorly controlled hypertension, severe hypertension. And when we tried adding phentermine, their blood pressure went up. In each of those cases, I would discontinue the phentermine, see their blood pressure go down some, try the phentermine again and see it go up again. And so we would do that cycle about 3 times. And then at that point, we said, we can't use phentermine in this patient. So the incidence is, less than 1 in 10,000 patients. Another risk that's mythical is that it induces heart disease. Well, there are a few things that it probably does do. It has been associated with coronary artery spasm in a few cases, but coronary artery spasm is a very common precursor to myocardial infarction. So that's a very common condition. So you have phentermine is the most widely used anti-obesity drug in the world. So at any moment in time, there are hundreds of thousands of patients taking phentermine. And so to say that the coronary artery spasm was caused by the phentermine, I think it's more likely coincidence. What about pathologic arrhythmias? Well, again, these are extraordinarily rare. Phentermine's never truly been associated with new onset atrial fibrillation. Yes, it's occurred in patients taking phentermine, but the incidence is very high, and most of the people who point to phentermine as their cause forget that the rate of occurrence, the rate of incidence is quite high among most populations. So what about valve disease? Has phentermine ever caused valve disease? And the answer is never. Patients do get occasionally, and the incidence is pretty low, on the order of something less than 10%. They do get palpitations, but these are non-pathologic. They're occasional, they're infrequent, and they're benign. Next, and so I don't discontinue phentermine when somebody has palpitations. We might discontinue it temporarily, but it's not associated with palpitations. What about pulmonary hypertension? I think all of the cases of pulmonary hypertension, I think the reporters of those cases always ignore the high incidence of pulmonary hypertension in the general population. In America, it's pretty well established that the incidence is one case per million population per year. So we would expect about 300, something over 300 cases of idiopathic pulmonary hypertension a year. And the incidence of pulmonary hypertension in obese subjects and overweight subjects is higher than in lean subjects. So I think we can discount the fact that pulmonary hypertension is caused by phentermine. Glaucoma, that's a theoretical contraindication. There's never been a report of phentermine-induced glaucoma or phentermine-induced worsening of glaucoma. But you have to be careful in patients with glaucoma. I mean, other physicians will criticize you. So what I do is, if I have someone with glaucoma and we want to use phentermine, I make sure that they've had recent, that they're being treated and recently their eye pressures are normal. And then we have them, followed by their ophthalmologist and tested at least once annually while they stay on phentermine. What about addiction? Addiction has never happened. We did a couple of addiction medicine studies. At one point, after I've been using phentermine for probably 20 years, almost 20 years, it occurred to me that that I constantly see patients who have come back, who come in, are treated, get their weight down, and then they drop out of treatment. And then they come back and they've regained their weight. And they've been able to stop, they typically stop phentermine abruptly with absolutely no problems. So after we realized that, we put together 2 addiction medicine studies. One of them was a clinical trial. We found absolutely no evidence of, there was no hint of anything like addiction. There was no hint of amphetamine-like abuse, of amphetamine-like, there's no amphetamine-like phentermine abuse syndrome or use syndrome, and there's no phentermine withdrawal syndrome. What about psychosis? Well, psychosis occurring in patients taking phentermine has occurred. It's very rare. There were a few cases in Australia reported a few years back where they took the patient off phentermine and the psychiatric symptoms, the hallucinations went away, and then they put the patient back on phentermine and they came back. So that's a little disturbing. I think you should avoid using phentermine in patients with overt psychosis. Certainly patients that are having hallucinations and out-of-body experiences and the like, I would avoid using phentermine. Their psychiatrist will blame you if they get worse. Whether that's true or not, I don't think anybody knows. Let's go to the next slide. So can you use phentermines in combinations? So remember, the FDA here for years said never combine phentermine with anything, and then they approved phentermine and topiramate as a combination. So now we know that phentermine may be combined with almost any medicine. So specifically, it can be combined with topiramate, obviously. It can also be combined with any other anti-obesity medicine. So I have patients who were on lorcaserin before it was taken off market, and they did very well with additional phentermine. I have patients who are taking bupropion, naltrexone combinations, and they all do well if you add phentermine. So Saxenda is the same as true. I do have a few patients that are taking Saxenda, even despite its great cost, and they do better if they take phentermine. What about phentermine and addiction deficit medicines? So the only hazard there is overstimulation, but I don't think I've ever seen anybody who got overstimulated. So phentermine works the phentermine works a little better for eating behaviors, and the attention deficit medicines, amphetamine salts, methylphenidates, some of the neuromedicines seem to work better for the attention deficit. So can you combine them? Yes, you can. You just have to be careful you don't overdo it. Um, there are psychiatrists in my community who are horrified when I when I use phentermine in a patient who's taking an attention deficit medicine. But there are others who I've worked with, and they know it's a perfectly safe thing to do if you see the patients fairly frequently and make sure they're not overdoing either drug. What about phentermine and hypertensive medicines? Well, I think it's best to not add phentermine when somebody's on a hypertensive medicine until their blood pressure is below 140/90. And if their blood pressure goes up, I tend to temporarily discontinue the phentermine until the hypertension's in control. And once it's in control, then I think it's perfectly safe to put the patient back on phentermine. Next slide, please. So worldwide, there are two phentermine formulations. One is a drug called duramine, which is phentermine attached to an ion exchange resin. And the molecular weight is lower than the phentermine hydrochloride. The phentermine the phentermine is attached to a hydrochloride molecule, and because of that molecule, the molecular weight is higher. So the molecular weight of phentermine hydrochloride is 185, of phentermine base is 149. Phentermine slow release is a hydrochloride form. Next slide, please. So what about the kinetics? This is phentermine hydrochloride. This is taken from a research paper by Addy 11 years ago, and it shows that if you give a single dose of phentermine orally, in this study they were looking at the combination of phentermine and a drug called turinabant. But if you look at the boxes here, phentermine alone is in the boxes, and so you see that an oral dose of phentermine reaches a peak plasma concentration at about 2 hours. And then 24 hours later, the plasma concentration is approximately half the maximal. And the next slide shows the Phentermine SR Kinetics, a slow release phentermine, and it's slower. So this is from the Kang paper on the phentermine trial in Korea. And what he was able to show is that the phentermine peak concentration with this particular form of phentermine is at 10 to 12 hours, and then the half concentration is quite a few hours later. This is a semi-logarithmic scale. So the phentermine, the slow release phentermine hangs around for quite some time. The next slide, please. This is another look, a different way of looking at that former slide was semi-logarithmic. These are linear slides. So again, the time peak, the concentration peak in terms of hours is in this study about 8 hours, maybe a little sooner than that. And then if you look at what happens over the 8 hours, it's a slow increase in, it's a slow release of the phentermine, which is the reason that the peak onset is, the peak plasma level is so much delayed. Next slide, please. So these are comparative pharmacokinetics. The Phentermine SR from the Kang paper and the phentermine hydrochloride from the Addy study. So the dosages were a little different. So the maximal concentration is different, but you see that the Phentermine SR concentration max is at about 12 hours, whereas the hydrochloride max is at about 2 hours, and the half concentration is at about 24 hours. In the case of phentermine hydrochloride, just a little shorter, but close to 20 hours. So let's go to the next slide.
Yeah, Dr. Hendricks. We received a notion from our Thailand attendees. They asked if you could speak a little bit louder to hear you a little bit better.
I'm sorry, I will. So let's go to the next slide. So Phentermine SR, this is from the Kang paper published in 2010. And then we're going to talk more about phentermine use. And so we're going to compare what was done in Korea with what was done in my practice, published in 2011. So the Kang study was a 12-week randomized placebo-controlled clinical trial with 37 paired subjects, and they were treated with 30 milligrams of phentermine slow release. In our study, it was a long-term observational study in 300 continuing patients on a ketogenic diet. 269 of them were on phentermine and 31 were on no medical treatment, no medication treatment. And the doses were variable, and we'll talk about that in a second. Next slide, please. So at 12 weeks, so we looked at the Kang study and the Hendricks study at 12 weeks. The participants, there were 37 in the Kang study and 269 treated with phentermine. Our patients were a little heavier. The initial weight in the Kang study, 87 kilograms, and in our study, 98 kilograms. And at 12 weeks, the Kang patients lost 8 kilograms. Our patients lost close to 15 kilograms. So the Kang patients at 12 weeks lost 9.3% of their initial weight, whereas our patients lost 15%. I think the major difference was that we used a ketogenic diet as opposed to a more conventional diet. Let's go to the next slide. So the next slide shows what happened at 52 weeks. Can we move to the next slide? There. Okay, so here we looked at 12 weeks, and that was the extent of the Kang study, and then we looked at 1 year. So at 12 weeks, the Kang study had about 97% of the patients had greater than 5% of weight loss. And at 1 year, 97% of our patients had greater than 5% weight loss. In the Kang study at 12 weeks, only 53% had greater than 10%, whereas at 1 year, 83% of our patients had greater than 10% weight loss. The dosages were different. In the Kang study, used uniformly a 30 milligram dose. We used a technique called dose to effect titration. So some of our patients were still at 30 milligrams, but some had advanced to 90 milligrams. There were minor adverse drug reactions in both studies. There were major drug reactions in none of the patients. Next slide, please. So this is from the Hendricks study, and it shows, the red line shows no phentermine. And so there was not a great deal, there was a significant difference in the weight loss between the patients who received no phentermine and the patients who were continued on phentermine. But as you see, at 2 years, the patients with no phentermine were already regaining weight. And by 3 years, they had regained almost all of their weight. There were a few that we had that persisted out to 4 years, but there were not enough to graph for you. But the phentermine patients, the major difference is that long-term phentermine helped the patients maintain a weight loss between 10 and 15% out to 8 years. Let's go to the next slide. So this is 174 patients in our study at 52 weeks. This is the weight loss at 1 year, basically. And you see there's the far left, what this shows is that each one of those blue lines represents one patient. So the mean weight loss at 1 year is 17.6%, but there's a wide variability between the individual patients. One patient on the extreme left actually had gained weight at 1 year. And the most extreme patient at the right side had lost 40% at 1 year. So there's quite a range of outcomes at 1 year, and that's true for the 2 and 3 and 4 and 5 year outcomes as well. Okay, let's go to the next slide. So this is a look at what's been reported in the literature of 7 to 10 year treatment effects. So in my study, we only were able to show, we only had enough patients to show out to 7 years, but in the diabetes prevention program, they had 10 years worth of data. And look at the data. At 10 years, the patients had, the average weight loss was about 2%. Average weight loss at 7 years in our study was about 10%. The red line is the Swedish obese study for gastric banding. And you see it 1 year and 2 years. Our study and their studies are pretty close. Then our patients began to gain some weight. But long-term phentermine gives you comparable results to gastric banding. Nobody recommends gastric banding anymore in the United States, and I don't think it's being done in the US. Most of the surgeons that have done banding before are taking them out now because of complications. And then we see at the bottom is the Swedish obese study with gastric bypass. Let's go to the next slide. So this is a look at, this is from the Vivus company's 1 year long-term study with phentermine topiramate. And remember, the phentermine topiramate comes in several doses. So the low dose at 1 year, about 7%, that's about what low-dose phentermine alone will do. I'm sorry, that's about what phentermine as a monotherapy has been reported to do in clinical trial. But look what happens when you do the top dose, you get almost 15% weight loss. So this is another example of how a combination works better than a monotherapy. Let's go to the next slide. So what happens to blood pressure? So we found on the right side is our data, on the left side is the phentermine topiramate data. And so the Vivus people stratified their patients at 1 year, and they looked at the difference between Q means the phentermine topiramate. So with no Q, the systolic blood pressure changed a little bit. There was a little bit of weight loss, maybe 2%, and not much change in the blood pressure. And if you looked at all of the patients, including the hypertensives, the systolic blood pressure came down about 5 millimeters of mercury. The diastolic blood pressure came down about 3 millimeters of mercury, and the yellow band shows the percent weight loss. And then with the hypertensive patients in the Phentermine topiramate long-term study. If you segregated those out and just looked at them, they had the greatest declines in blood pressure. So about 9 millimeters of mercury in the systolic blood pressure, and about 6 millimeters in um, the hypertensive, in the diastolic blood pressure, and they had a significant weight loss. On the right side are our patients, so no Phentermine therapy, keto diet only, and you see they had about, and this is unselected patients, all just no Phentermine patients, no distinguishing between hypertension or no. And then if you look at the Phentermine patients on the two right clusters, all patients showed about a 7 millimeters of mercury decline in systolic blood pressure and about 5 in the diastolic blood pressure, with significant weight loss of close to 18%. The hypertensive patients showed the greatest decline in blood pressure. So the people who say that Phentermine causes an increase in blood pressure have got it backwards. Weight loss with Phentermine in all patients leads to declines in blood pressure. Weight loss in hypertensive patients leads to even greater declines in blood pressure. So Phentermine in hypertensive patients is a benefit in terms of blood pressure. Phentermine in unselected patients, as far as blood pressure goes, is a benefit in terms of blood pressure. Next slide, please. This is what happened to this systolic blood pressure in the normal blood pressure patients in our study, in the pre-hypertensive patients, and in the hypertensive patients. So the hypertensive patients had the greatest declines in blood pressure. Many of the pre-hypertensive patients still had declines in blood pressure at 1 and 2 years. Next slide. So Phentermine provides cardiovascular benefit, not cardiovascular harm in overfat, overweight, and obese subjects. What about the categorical? So I always say that Phentermine is the best of all the weight loss drugs. And why do I say that? Well, this slide gives you some idea. So if you look at the first, so the agents are in the first column. The second column is how many patients at 1 year lost greater than 5%. And Phentermine's got the best statistic, 97% of the patients greater than 5%. That's from my paper. The other numbers are from Dr. Tim Garvey's paper, where he compared, he didn't compare Phentermine, he compared all the other drugs to each other. And so Phentermine topiramate at 1 year greater than 5%, 70% greater than 10%, 48%, and greater than 15% not available. Bupropion, oh, go back, yeah. Lorcaserin, 48% at 1 year, greater than 5%, 23% greater than 10%. Nobody had any numbers for 15%, and lorcaserin's gone forever. Bupropion, naltrexone, 48%, had greater than 5% at 1 year, 25% at greater than 10% at 1 year, 15% greater than 15% at 1 year. So on this basis, I think Phentermine is the best drug. If you look at dropout rates, the dropout rates are much higher for all these other drugs than they are for Phentermine. Phentermine is moderately inexpensive, and it's sustainable. The patients can afford it, and they will stay on it. Liguratide in America costs about $1,200 a month. It's not a sustainable medicine. Insurance companies that cover it will drop the patients after a year or more. Let's go to the next slide. So, adverse cardiovascular effects, blood pressure elevation, no. Pulmonary hypertension, no. Cardiac bowel pathology, no. Arrhythmias, no. Is it a contraindication in coronary heart disease? No. Does it cause sudden cardiac death? Well, there's no evidence that it does. That's a very common thing. Occasionally you'll find a report, but it's, I call them lightning strike reports. You know, I gave the medicine to this patient, they walked out the door and they got struck by lightning. It's a bad medicine. Obviously, that's not a rational way to think about it. Palpitations, yes, most often due to homeless premature contractions. The incidence is low. Next slide, please. What about addiction? 61 years of use, been no addiction. Clinical observations, you know, lots of clinical observations. No one's ever seen addiction. So in the DSM-5, is there an amphetamine-like substance use syndrome called the Phentermine substance abuse syndrome? No, it's not been described. Is there an amphetamine-like withdrawal syndrome? No, there's not. Is there abuse? Well, abuse means non-prescribed uses. And using that definition, yes, there is some abuse. It's seen in polydrug users. Sometimes polydrug users will add phentermine to their cocktail in the hopes that it'll increase the stimulant effect, but they're always disappointed, and phentermine is not sold on the streets of America. It's traded mostly to long-haul truck drivers who use it to stay awake, and to students who use it to concentrate better when they're studying and stay awake. There's no evidence of harm in either one of those groups. So I would say, you know, the abuse thing is sort of it's mythical. What about phentermine adverse central nervous system events? There have been a couple of cases of stroke. So if that's all there is, the risk is extraordinarily low. Psychosis induced by phentermine, there have been a few cases reported, but any stimulant can induce psychosis, and the incidence is proportional to the stimulant's strength. So amphetamine is about 10-fold stronger than phentermine is in terms of stimulant strength. There's a high risk of psychosis risk with amphetamine use, especially with amphetamine addiction. What caffeine can cause psychosis as well if it's overused, but it's very low risk, and the amphetamine risk is extraordinarily low. What about epilepsy? Well, there's no known association with phentermine use. Next slide, please. What are the actual adverse effects? Well, insomnia. These are all from a paper in Korean Journal of Family Medicine by Dr. Kim, and he found that he and his co-authors found that insomnia occurred in about 11%, but that it faded with the insomnia disappeared with continued use. Dry mouth is a common side effect, but usually the patient says it's tolerable. It reminds them to drink more water, which is beneficial when you're trying to lose weight. A few people show up with dizziness. There is an occasional constipation, occasional nausea, palpitations about 2%. Let's go on to the next slide. The less common adverse effects that are seen are, and these are less than 2%, a headache, anxiety, tremors. I have lots and lots of patients who have anxiety, and very rarely do they say phentermine, the addition of phentermine increases their anxiety. What they do say is that if they take phentermine, it may lower the uh, the threshold for anxiety. For example, patient will tell me, well, I can get into an elevator with 4 people, but if I take phentermine, I can only get into an elevator with 2 people. So it lowers their threshold for anxiety. Uncommon, less than 1% tachycardias, 0.4%. It's not very common. Bruxism or teeth grinding, that does occur, and sometimes you have to stop the phentermine. Men with prostatic difficulties, the phentermine can stimulate closure of the, the sphincter muscle at the bladder outlet. And if they have prostatism, that sphincter is already somewhat closed. You put them on phentermine, they have trouble urinating. You can use a drug we call Flomax, and it will open that sphincter and they don't have any trouble. It does cause impotence occasionally, and it can cause overstimulation. Next slide. So what are the beneficial effects? Weight loss, clinical improvements, reversals of the comorbidities. Patients who continue long-term phentermine have more successful weight loss maintenance. Phentermine can help counteract drug-induced weight gain. It's not perfect, but it helps. It can halt or slow weight gain from any cause. You get improvements in their dietary compliance. You get improvements in their eating cognition. You get improvements in their eating behaviors, and it can eliminate or subdue food cravings. Next slide. So these are the treatment effects, and we pretty much covered those in that one graph I showed you, the long-term 10-year outcomes. So let's go to the next slide. In summaries, phentermine is still the best anti-obesity medicine. It is now and always has been. I don't see anything on the horizon that will be better. Monotherapy or combined therapy is extraordinarily safe. There are fewer side effects because of the kinetics with phentermine slow release. In my experience, the ketogenic diet is most effective. And the keys for successful long-term maintenance are phentermine, continuing in nutritional ketosis, and adding metformin. So that combination of nutritional ketosis, phentermine, and metformin, I think, is the best medical combination we've ever had. Next slide. So I thank you very much to our participants, to our sponsors, including Eurodrug, Bukwang, and the Thailand and Singapore affiliates. Now we have time for questions if anyone has questions. Thank you so much.
Yes, thank you, Dr. Hendricks. We're now going to handle some questions. For the audience, I would like to note that if you have any questions, please leave a message in the chat box and I will handle the questions with Dr. Hendricks. First question arising is like you showed at the beginning that the cytokines are uplifted already before even the start of the cytokine storm. Can you elucidate a little bit more why the cytokines are uplifted in an obesity situation?
Well, being over, fat accumulation, excess fat accumulation at any stage is an inflammatory disorder. That was shown by some people at the Columbia University some years ago when they used, they got an obesity prone colony of mice from purebred mice they're genetically identical, and they used they used a chip that was a gene chip and not a computer chip. And they found they used. I'm trying to think of the name of the company, but it's a company that handles and raises and offers for sale colonies of genetically identical mice to be used in medical research. And so they used a murine gene chip. A company called.
Sorry, Dr. Hendricks, you're very hard to hear right now. Could
I'm
you
sorry.
speak?
I'm sorry.
Yeah.
Anyway, these Columbia University specialists showed that the obese mice had something like 3,000 inflammatory genes turned on as they gained weight. And many of those genes have to do with inflammation, and many of those have been identified in humans. And so there's a long, long list of inflammatory genes that become activated as fat accumulates. And so what you have is you have a pre-existing inflammatory condition, low grade, in an obese subject, and which makes them prone to developing cytokine storm. Many of those inflammatory genes, many of the inflammatory agents are cytokines.
Yeah, all right. So because of the state in which the people are already in, like this low state induced inflammation, you continuously get those cytokines spit out by those cells and in the systemic blood circulation of the patient. All right. In regards to so what would you advise for we're now in a pandemic situation? A lot of patients are very afraid that they will end up in hospital in the ICU. What would you advise doctors to advise their patients regarding Phentermine use? Is it effective to also develop some short-term benefits?
Of course, it's effective short term. The only problem is you don't solve the inflammatory condition. And the patients almost, if you do short term Phentermine, the patients and then stop, the patients invariably regain their weight, sometimes even more weight than they had before. So if you're going to use Phentermine, my advice is you use it long term. I know that's not according to the label. You're using it off label if you do that. But that's what benefits the patient the most.
Yeah, because in your practice, you stated that you have over 30 to 50,000 patients treated. I also saw that you had, between the two studies you showed with the sustained release and the normal release, I saw that you had between 30 and 90 milligrams compared to 30 in the sustained release dose. What was the reason that you give an uplifted amount of Phentermine to those patients? Do you see a lack of treatment response, or is it just?
So, first of all, the patients all will say, if you give them a 30 if you use a fixed dose and you start them on a fixed dose, whatever that dose might be, 30 milligrams in the case of Phentermine SR, after a month, after a time, they say, it's not working as well. And so what most of the obesity medicine docs in America have done is they said, well, okay, let's increase the dose and see if it works better. And it almost always does. Not every patient goes through that. I have patients, so a standard adult dose for an adult in America is a 37.5 milligram phentermine hydrochloride tablet. And we tell them, if they're sensitive to stimulants, we tell them, break the pill in half and just take half a pill. And I still have a few patients that have been on Phentermine for 10 years and are still taking just a half a pill. But most of them, but the average dose in my patient population, and the average dose across the US seems to be 1.5 pills a day. And some people need even more than that. If they, patients with attention deficit benefit from taking more phentermine. And so they end up wanting to treat both illnesses with phentermine. And those patients, I have patients that so the highest dose I'll use is 3 tablets a day. And nearly every one of those patients in my practice have severe attention deficit disorder. Some of them are on attention deficit medicines and some aren't. I always tell them, you know, I think you do better. Let me refer you to a psychiatrist who deals with attention deficit, and those guys charge a lot of money, more than I do, and many of the patients say, no, I can't afford that. If they have insurance, though, they go see one of those guys, and they end up sometimes on both medicines. But even when they're on both medicines, sometimes they need more than the standard dose of phentermine.
Yeah. There's a quite similar question arising from the audience as well, and it is regarding, like, you show a lot of trial results. What is, in your experience, the most striking difference between trial and practice? Of course, you already stated that you sometimes give a higher dose if you feel like the patient feels like it's not working as much anymore. Is there another striking difference?
So the difference between a clinical trial and private practice is, first of all, the patients stick with you longer, and you don't have to follow a rigid protocol. So I just rechecked this last month, and I checked on the longevity of 100 consecutive patients. How long have they been patients? And the average was 9 years. So in a clinical trial, you don't have that kind of long-term relationship with the patient. And so my patients trust me. I mean, those patients that have been coming for 9 years, I remember one patient told me, he said, well, you've been doing this a long time. I was explaining to him why we use drugs off-label. And he said, and he'd been coming for a while. And he said, well, you've been doing this a long time. If you were doing anything wrong, you'd probably be in jail by now. Nice vote of confidence. But,
Nice.
so years ago, I decided I was going to use drugs off-label because it's silly, I think, it's silly to expect almost any medicine. There are a lot of medicines where you have to titrate to effect. I mean, you start out and the patient's drug detoxification mechanisms are just barely working, but as they get exposed to the medicine more and more, they become more efficient, so they get rid of the medicine more quickly, and you have to increase the dose. I mean, that's pretty much standard practice in medicine with many, many medicines. So the idea that a single standard dose is suitable for everybody, it's like saying, you know, one size of a pair of pants fits everybody. So the manufacturer, you're only allowed to make one size of blue jeans or trousers. That's ridiculous. People are different.
I can completely imagine. XS would definitely not fit me. There's a question also arising from the audience. Does phentermine have any serotonergic or dopaminergic effects? Dopaminergic.
It does have. It doesn't have any serotonergic effect. It does have some dopaminergic effect, but it's pretty weak. And some have speculated that's the reason why there's been no addiction.
Yes. So that's also concludedly a minor dopaminergic effect and no serotonergic effect. That's what you're saying.
Right.
Yes. All right. So I believe that those are the questions. Oh wait, there's one more question regarding the sustained release. So the phentermine of your drug is in a capsule. Can it be opened? Is the question. I think that's one that.
Yes, I would think it could be opened. I mean, those, yeah, that's a way to get a lower dose. So you could cut the capsule and open it and have them sprinkle it on food, or put it in some water and let it dissolve in the water and drink the water. So there are various ways you could do that. Yeah.
All right, that's nice to hear. So with that, all the questions are just answered. I would like to thank you very much, Dr. Hendricks, for giving this presentation, and I would also like to thank the audience. Thank you for joining this webinar. If there are any questions which are left out or which haven't been answered, please feel free to contact Eurodrug or your local affiliate regarding these questions, and we will try to follow up them up as fast as possible. This webinar will also be available on YouTube in the near future, so that you can share the webinar with your colleagues if necessary. Again, thank you for joining our webinar, and hopefully until next time. Again, thank you, Dr. Hendricks.
Thank you.
Eurodrug. We research for the human needs of tomorrow.